Welcome back to the deep dive. We are continuing our journey through the course, Integrated Neurobiology, Structure, Function, and Pathology. And frankly, I think we both need to take a deep breath.
I think so. We have officially survived Module 1.
We have. And for anyone who felt like they were maybe, drowning in Nernst equations and G-protein coupled receptors during those first 3 lectures, today is going to feel like coming up for air.
I hope so. It really is a shift in perspective.
Yeah.
And look, those first lectures, they are the foundation. They're essential.
Absolutely. Module 1, cellular foundations and neurophysiology, you have to have it. You can't understand the brain if you don't understand the ion channel.
Right. But it is abstract. It's invisible. It's mathematical.
It is.
But today, we're turning the page. We're entering Module 2, Neuroanatomy Overview and the Physical Environment, and we're finally looking at the thing itself. This is lecture.
And just to orient everyone, we are strictly following the course syllabus. So we're working off the designated 15 slides for this lecture, and we're leaning very heavily on 2 of the Bibles of the field.
The big ones.
Blumenfeld's Neuroanatomy through Clinical Cases. We're really in Chapter 2 today, and of course, Haynes' Neuroanatomy Atlas, Chapter 4.
And this transition, going from the micro to the macro, it's not just a change in scale. It really is a change in mindset. Blumenfeld has this wonderful metaphor right at the start of the chapter.
Oh, the mural. I love that.
Yes. He compares learning neuroanatomy to painting a mural.
He says you don't start with the eyelashes on a face or the individual bricks in a wall.
Exactly. If you start with the tiny details, you end up with a mess. You have no context. You have to start with the rough sketch. You need the composition. You have to know where the sky is and where the ground is before you even think about the texture of the clouds.
So that's our mission statement for this deep dive. We are sketching the mural. We are not going to name every single nucleus in the brainstem today. That will come much, much later.
God, no.
Today is about the framework.
And honestly, for you, for the physician scientist, this framework is absolutely non-negotiable. You cannot localize a lesion, which is the entire point of clinical neurology, if you don't understand the 3D architecture.
Right.
And here's the kicker. You cannot understand the architecture unless you understand the history of how it got that way.
Which means we have to talk about embryology.
We have to. It's unavoidable. The adult brain is confusing. I mean, it's twisted, it's curled, the names don't seem to match the locations. But if you look at the embryo, it all unravels. It starts to make sense.
Well, let's stop talking about it and start building it. We have 15 slides to get through, and we're going to go through them sequentially to build this map. So let's bring up slide 1, title and learning objectives in our minds.
And visually, this slide really sets the stakes. You have this composite image.
Yeah.
On the left, there's a 4-week neural tube. Looks simple, almost like a little cane or a hooked worm. And then on the right, you have a T1-weighted MRI of a full adult brain, which looks like this, kind of a chaotic explosion of folds and gray matter.
And the text gives us our 4 objectives to bridge that gap. Number 1 is to define neuroanatomical orientation.
Which is harder than it sounds.
We will get to that for sure. Number 2, trace the differentiation of primary and secondary brain vesicles. Essentially how that simple tube swells up into the brain.
Right, the embryology.
Number 3, differentiate cellular organization, gray matter versus white matter.
The building materials.
And finally, number 4, analyze protective layers, the meninges and their spaces.
And that 4th one, that's where the pathology part of our course title really, really kicks in. I mean, understanding the meninges is literally the difference between life and death in a trauma bay.
So form follows function, but also form follows survival.
Precisely. This isn't just memorizing Latin names. It's about understanding connectivity.
Right.
And it's about understanding what can go wrong.
Okay, let's jump right into the deep end then. Let's go to slide 2. Neuroanatomical orientation and the cephalic flexure. Now, I was looking at the diagrams in Haynes, and This seems to be the first major stumbling block for every single medical student.
It is. It's the coordinate singularity of human anatomy. It breaks everyone's brain at first.
Explain that, because if I look at a dog or a shark or a lizard, the whole nervous system is just a straight line. The nose is the front, the tail is the back. It's simple.
Exactly right. In a quadruped or a fish, the neuraxis is linear. Rostral means toward the beak or nose. Caudal means toward the tail. Dorsal is the back think of a dorsal fin, and ventral is the belly. You can run a perfectly straight line from the tip of the nose to the tip of the tail, and those directions never ever change.
But humans, of course, had to be difficult and stand up on 2 legs.
Well, evolution is messy. When we became bipedal, our spinal cord became vertical, but our eyes still needed to look forward at the horizon, not up at the sky. So nature put a bend in the system.
The cephalic flexure.
That's the one. There is a roughly 90-degree bend that occurs right at the junction of the midbrain and the diencephalon. This bend allows the forebrain to remain horizontal while the brainstem and the spinal cord drop vertically.
And this creates a complete nomenclature nightmare.
It does. It effectively splits the central nervous system into two separate coordinate systems. So below that flexure, in the brainstem and the spinal cord, we use what I call the lizard coordinates.
The lizard coordinates. I like that.
Rostral is up toward the head, caudal is down toward the tailbone, ventral is anterior toward your chest, and dorsal is posterior toward your back.
Okay, that part feels intuitive. Dorsal is my back. I can remember that.
But, and this is the but that fails exams, once you cross that midbrain diencephalic junction and you enter the forebrain, the whole axis rotates 90 degrees forward.
So in the brain itself, the cerebral hemispheres.
Right. In the forebrain, rostral still means toward the nose, but now that's anterior. Caudal means toward the back of the head, which is posterior.
And dorsal, this is the one that gets me.
Dorsal now means the top of the head, the superior surface. The easiest way to remember this is to picture a shark fin sticking out of the top of your skull. That's the dorsal surface of your brain.
And ventral, by extension, must be the bottom.
Ventral means the bottom of the brain, the inferior surface, the part that's resting on the skull base.
So if I'm a radiologist and I'm looking at a scan of a patient and I say the word dorsal, I have to be incredibly specific.
You have to.
Dorsal aspect of the spinal cord is pointing one way, and dorsal aspect of the parietal lobe is pointing a completely perpendicular direction.
Exactly. And it gets even stickier when you start talking about planes of section. If you take a horizontal or axial slice, you're cutting parallel to the floor, right?
Right.
In the forebrain, that cut goes neatly from dorsal to ventral. But if you keep that same cutting plane going down through the brainstem, because the brainstem is now vertical, you're actually cutting it in a sort of oblique cross-section.
So you have to mentally rotate your map as you scroll down through the MRI slices.
You do. You have to constantly navigate that bend. That cephalic flexure is the anchor point for all 3D navigation in the human head. You have to master it.
Okay, so that's the why of orientation. Let's move to the what. Slide 3, embryogenesis, the primary vesicles. We are going all the way back to 4 weeks gestation.
We are. At this stage, we are basically just a tube. The neural tube. It's derived from the ectoderm, the outermost layer of the embryo, and at the head end of this tube, it starts to blow up 3 little balloons. These are the primary vesicles.
The 3 vesicle stage. And the names here are pure Greek?
They are, but they're descriptive. They all end in cephalon, which means head. The one at the very front is the prosencephalon. Pros means before or forward. So this is the forebrain.
Simple enough. Then the middle one.
Mesencephalon. Meso just means middle. So the midbrain.
And the one at the rear.
The rhombencephalon. Hindbrain.
That refers to a rhombus, right?
Uh-huh.
A diamond shape.
It does, yes. And that is not incidental. It's a clue. When we look at the fourth ventricle later on, we'll see that it's literally diamond-shaped. The anatomy is naming itself right here at 4 weeks.
I want to pause on one word mentioned in the slide notes. The lumen. We talk about these vesicles as swellings, but it's important to remember they aren't solid balls of clay.
No, absolutely not. They are hollow. That is one of the most critical concepts in all of neuroanatomy. The neural tube is a pipe. That hollow center never, ever disappears. It gets stretched, it twists, it narrows in places, but it remains a continuous, fluid-filled space.
And that hollow space becomes the ventricular system in the adult brain.
It's the direct descendant. So the fluid-filled spaces deep inside our brain are basically the ancient, saltwater-filled interior of that primitive tube.
That's a beautiful way to think about it. We carry that primordial ocean right inside our heads.
We really do.
But 3 parts is obviously not enough to make a complex human brain, so we have to proceed to slide 4. The secondary vesicles and adult derivatives. This is the 5 vesicle stage.
Right. At about 5 weeks gestation, things get more specialized. The prosencephalon, that forebrain, it splits into 2.
And this seems to be where the real drama happens.
Oh, it is. This is the main event of brain development. The most rostral part becomes the telencephalon. Pel implies end or distance, like in telephone or telescope. This is the end brain.
And looking at the diagram on the slide, the telencephalon seems to be, well, aggressive is the word that comes to mind.
It's the colonial power of the nervous system. The telencephalon is destined to become the cerebral hemispheres. That means the cortex, the deep white matter, the basal ganglia, In humans, this region undergoes such a massive explosive growth that it just runs out of room in the skull.
It can't go forward because it hits the front of the skull, so what does it do?
It curls backward. It grows up, then back, and then it loops down and forward, almost like a ram's horn. Blumenfeld calls it a mushroom cap, growing over a stem, which is a good image.
But I like the ram's horn better.
I do too, because it captures the crucial element of rotation. This rotational growth is key.
And in the process, it just covers up everything else.
It completely envelops the diencephalon and the brainstem. This is why you can't see the thalamus from the outside of a brain. It's completely buried under the overgrown telencephalon.
Okay, so the prosencephalon gives us the telencephalon and the diencephalon.
Right, and dia means between. The diencephalon is the between brain. It's perfectly named. It's sandwiched between the two cerebral hemispheres, and it serves to link them to the rest of the body. Its adult derivatives are the thalamus and the hypothalamus.
Then we have the mesencephalon.
The mesencephalon is the stoic one. It's simple. It does not split. It remains the mesencephalon. In the adult, we just call it the midbrain.
And finally, the rhombencephalon, the hindbrain.
That one divides. It splits into the metencephalon, which becomes the pons and the cerebellum, and the myelencephalon, which becomes the medulla oblongata.
Myle usually refers to marrow, or in this case, the spinal cord, right?
Exactly. The myelencephalon is the transition zone. It's the most caudal part of the brain, and it funnels directly into the spinal cord.
So we have the sequence, rostral to caudal, telencephalon, diencephalon, mesencephalon, metencephalon, myelencephalon.
It sounds like a spell from Harry Potter.
Yeah.
But if you can learn that sequence, you have the fundamental rostrocaudal organization of the entire brain.
Now, slide 5. The neural tube lumen to ventricular system mapping. This basically takes that hollow tube concept we just talked about and overlays it on the 5 vesicles we just named.
This is a slide that separates the people who just memorize from the people who truly understand. If you just try to memorize the fact telencephalon equals lateral ventricles, you might forget it under pressure.
Right.
But if you visualize the telencephalon expanding like a giant balloon, it's obvious that the space inside that balloon has to expand with it.
So the lateral ventricles are simply the cavity of the telencephalon.
Correct. And because the telencephalon did that huge ram's horn rotation, the lateral ventricles are also, by necessity, C-shaped. Form follows history.
Then we move down to the diencephalon.
The diencephalon doesn't expand like the cortex. It stays put right in the middle. So its cavity remains a narrow vertical slit that's sandwiched between the two halves of the diencephalon, between the two thalami. This is the third ventricle.
And then the mesencephalon.
Well, the midbrain stays small and compact. It's a conduit, so its lumen narrows down into a tiny, tight little tube. This is the cerebral aqueduct, also called the aqueduct of Sylvius.
That seems like a design flaw. You have these 2 massive lakes of fluid upstream in the lateral ventricles, and then this one tiny little straw to drain them.
It is a massive vulnerability. We call it a bottleneck, literally and figuratively. If you have a small tumor in the midbrain or just some swelling from an infection or a bleed, you can easily pinch off that aqueduct.
And the fluid keeps being produced upstream in the choroid plexus.
Exactly, but it can't get out. So the pressure builds, and the lateral and third ventricles balloon out because they can't drain. That is non-communicating hydrocephalus, the water on the brain.
So it's really just a plumbing backup.
It's a plumbing backup caused by the embryological narrowing of the mesencephalon's lumen.
Wow. That makes the clinical picture so much clearer. If I see a scan with huge ventricles on top and a normal-sized ventricle on the bottom, I know exactly where the blockage has to be.
It has to be the aqueduct. There's nowhere else it could be.
Moving on, the metencephalon and myelencephalon, the hindbrain.
Here, the cavity opens up again to film the 4th ventricle, that diamond shape we mentioned earlier, before it finally narrows down into the very thin central canal that runs down the center of the spinal cord.
Excellent. Okay, let's shift gears a bit. We've built the gross shape of the house. Now let's look at the building materials. Slide 6. Basic cellular organization.
All right, we're zooming way in just for a moment. We need to define the building blocks to understand the colors we see when we look at the macroscopic brain.
And the 2 main players are neurons and glia.
Neurons are the divas. They get all the press, all the attention. They are the signaling units. They have dendrites for input, the cell body for integration and keeping the cell alive, and the axon for output.
And the glia.
The glue, the supportive cast. But as we will discuss in much more detail in Lecture 7, they are so much more than just glue. But for today's macroscopic purpose, we really only care about 2 types.
Okay.
oligodendrocytes in the central nervous system, and Schwann cells in the peripheral nervous system.
Because they both make myelin.
Yes, and myelin is a fatty substance. It's lipid-rich. Fat, to the naked eye, looks white. This single fact is the entire basis for the visual distinction between gray matter and white matter.
Which takes us perfectly to slide 7, gray matter organization.
Gray matter is gray because it lacks that fatty myelin. It is composed primarily of neuronal cell bodies, dendrites, and the synapses between them. This is where the computation happens. This is the thinking part of the brain.
Now, the slide distinguishes between cortex and nuclei. They are both gray matter, but they're arranged very differently.
Think of cortex as a sheet, like the skin or the rind of a fruit. It covers the surface. The cerebral cortex and the cerebellar cortex are these vast, crumpled sheets of processing power.
And we have to crumple them, the gyri being the bumps and the sulci being the grooves, to fit them all inside the skull.
Precisely. If you were to flatten out the human cerebral cortex, it'd be about the size of a large pizza. You can't fit a pizza in a skull without folding it up very, very carefully.
And nuclei, what's the difference?
A nucleus in neuroanatomy is a cluster of neurons, a chunk of gray matter that's buried deep inside the white matter. It's like a seed inside the fruit. The thalamus, the basal ganglia, the cranial nerve nuclei, these are massive chunks of gray matter, but they are deep, not on the surface.
Now, if you look at the diagram of the spinal cord on the slide, it looks inverted.
It is. It's inside out compared to the brain.
Yeah.
In the brain, the gray matter is on the outside, in the cortex. In the spinal cord, the gray matter is on the inside. It forms that characteristic H shape or butterfly shape right in the center, and it's surrounded by white matter.
Why the flip? Is there a reason for that?
There is. It's all about connectivity. In the spinal cord, the white matter needs to be on the outside because it consists of these long cables running up and down the spine to get to and from the brain. They are highways, so they need to be on the perimeter. In the brain, the processing needs to be on the surface to maximize that surface area for all the complex circuits.
Speaking of those cables, let's move to slide 8, white matter organization.
The white matter. This is the wiring harness of the central nervous system. It is white because of the myelin sheaths that are wrapping the axons. Its only job is transmission. It connects the different gray matter areas.
But the naming convention here can be really overwhelming for students. We have tracts, fascicles, lamicci, commissures, peduncles. Are these just synonyms for a bundle of wires?
They're nuanced. They're not exactly synonyms. A tract is usually a long, functional highway that connects point A to point B. The corticospinal tract is the classic example.
Okay, fascicle.
That's just Latin for a little bundle. It usually refers to shorter association connections with an hemisphere, a lemniscus.
That's a weird one.
It means ribbon. It's a great name. These are tracts that flatten out into a ribbon-like shape as they run through the crowded real estate of the brainstem. The medial lemniscus is a good example.
And my personal favorite, peduncle.
Peduncle means stalk, like a mushroom stalk or a flower stalk. These are massive structural pillars of white matter. The cerebellar peduncles are these 3 thick trunks that physically and functionally attach the entire cerebellum to the brainstem.
Why do we need to know this distinction? I mean, why not just call it all white matter?
Because white matter pathology is about location, location, location. If you have a stroke in the cortex, in the gray matter, you lose a specific function. Maybe you can't move your hand. But if you have a lesion in a peduncle or in the internal capsule, another huge white matter structure, you are cutting the main trunk line for an entire half of the body.
You're taking out the whole highway.
You're taking out the highway. White matter lesions are often more catastrophic because all the fibers are packed so densely together. High density means high stakes.
Right. High stakes. Okay, let's look at the negative space again. Slide 9. The ventricular system. Morphology. This slide shows a 3D cast of the ventricles.
I love these casts. They look like a piece of abstract alien art, don't they? But again, you have to remember our rule. Form follows history.
And we can see that immediately with the lateral ventricles. They are huge.
They are. And look at the shape. It's a perfect C shape. It has an anterior horn or frontal horn extending forward, a body extending back, a posterior or occipital horn pointing to the very rear. And then this is the key, an inferior or temporal horn that curves down, forward, and inward.
It's the ram's horn again.
It is exactly the ram's horn again. The ventricle was simply dragged along for the ride when the telencephalon did its big rotation during embryogenesis. And it's not just the ventricle. The caudionucleus, which is a deep gray matter nucleus, follows this exact same C shape, running right alongside the ventricle.
I see it in the diagram.
And the fornix, a white matter tract, follows the same C shape.
So if you know the C-shape of the lateral ventricle, you basically know the shape and orientation of the deep anatomy of the entire cerebral hemisphere.
Precisely. They are concentric C-shapes nested inside one another. Learn one, and you've learned them all.
Then we have the third ventricle, which is that narrow slit between the two thalami,
Yep.
and the fourth ventricle. The slide here says diamond or tent-shaped.
Right. Think of it like a tent that's been pitched on the back of the brainstem. The floor of the tent is the dorsal surface of the pons and medulla, and the roof of the tent is the cerebellum.
And the fluid inside all this, let's talk about that. Slide 10, CSF production and circulation.
So this is a dynamic system. This isn't a stagnant pond. The brain isn't just sitting in old water. It's a constantly flowing river.
And where does that river start?
It starts at the choroid plexus. This is very specialized tissue. It looks like little tufts of capillaries, and it's found inside all four of the ventricles. Its job is to filter blood plasma and actively pump out clear, colorless cerebrospinal fluid, or CSF.
And the flow is strictly unidirectional.
Absolutely. Blumenfeld uses this great swimming metaphor. Imagine you are a microscopic swimmer starting in the lateral ventricle. To get out, you have to swim through a small channel called the foramen of Monro.
That takes you into the third ventricle.
Right. From there, you swim down the narrow cerebral aqueduct, and you have to kick hard to avoid getting stuck. And that drops you into the fourth ventricle. Now, here is a critical point. Up until now, you have been inside the brain tissue, within the lumen of the neural tube.
But to do its job, the CSF needs to get outside the brain to coat the surface.
Exactly. It needs to get into the subarachnoid space. So how does it escape?
There must be some holes.
There are three holes in the fourth ventricle. The two lateral foramina of Luschka and a single medial foramen of Meninges.
Luschka and Mandley, another two names to remember.
They are. Once you exit those holes, you pop out into the subarachnoid space. Now you're free to swim all around the outside of the brain and the spinal cord.
What is the point of all this fluid? I mean, it seems like a lot of trouble to produce and circulate it.
It's buoyancy. This is basic physics. The human brain weighs about 1,400 grams. It's incredibly soft, like tofu or custard. If it just sat on the hard, bony floor of the skull under the force of gravity, it would crush its own bottom surface. It would compress the blood vessels in the cranial nerve.
It's suspended in liquid.
Archimedes' principle. The effective weight of the brain floating in CSF is reduced to about 50 grams. It floats. That is what allows us to have these massive, heavy brains without crushing our own brainstems.
That is incredible. It's basically a self-contained flotation tank.
It's a flotation tank, it's a shock absorber, and it's a chemical buffer. But buoyancy is its number one job.
Which brings us to slide 11, Introduction to Neuroradiology of Ventricles. We touched on this already, but let's formalize it. How do we see this on a scan?
We need to know what this fluid looks like. On a CT scan, which uses X-rays, CSF has a very low density. It looks black.
And on MRI?
It depends. On a T1-weighted MRI, fluid is also black. But on a T2-weighted MRI, fluid is bright white. The classic mnemonic is H2O is bright on T2.
Why do we care so much about looking at the ventricles?
Because looking at the ventricles is the fastest way to assess intracranial pressure and mass effect. If the ventricles are tiny, slit-like, smashed shut, you know the brain is dangerously swollen.
And if they're huge?
You have hydrocephalus, or potentially atrophy, where brain tissue has been lost. But if one ventricle is pushed over to the side, you know there has to be a tumor or a bleed pushing it. Symmetry is your best friend here. Any asymmetry is a red flag.
Okay. Let's move to the protective wrapping. Slide 12. The meninges, the pia layers.
Right, so we have the brain floating in its fluid tank. Now we need to put a lid on the tank and contain that fluid. We have three protective membranes. The mnemonic is PAD. From the inside, touching the brain, moving out.
Let's start at the brain surface then. The P for pia.
Pia mater, that's Latin for tender mother. And it is. It's delicate, it's microscopic, it adheres intimately to the surface of the brain. It dives into every single sulcus, coating every gyrus. You literally cannot peel it off without ripping the brain tissue itself.
Next layer out is the arachnoid.
The arachnoid mater. The spider-like mother. It's named for the cobweb-like filaments, the trabeculae, that connect it down to the pia. But here is the key anatomical difference you have to know.
Okay.
The arachnoid does not dive into the sulci. It bridges over them, from the top of one gyrus to the next.
So that creates a gap.
Yes, between the arachnoid, which is bridging over the top, and the pia, which is diving deep into the sulcus. You have a real physical space. This is the subarachnoid space. That is where the CSF lives, That is where our little swimmer swims.
And finally, the dura.
The dura mater.
Tough.
Mother.
Okay.
And it is tough. It's like leather. It's a thick, fibrous, protective layer that adheres to the inner surface of the skull. It provides the rigid structural support for the entire system.
This leads us directly to what might be the most clinically important slide of the day. Slide 13, meningeal spaces and hemorrhage types. This is where the anatomy becomes a survival guide.
It really is. We have 3 key spaces, and bleeding in each one tells a completely different story with a different cause and a different outcome.
Let's start with the epidural space. Epi means above, so above the dura.
This is a potential space. Normally, the dura is glued tight to the inside of the skull. There is no space there. To create one, you need to force something in there under high pressure.
Like an artery bursting.
Exactly. The middle meningeal artery runs in a groove on the inner surface of the skull, just outside the dura. If you get hit in the temple with a baseball bat, you get a skull fracture, and that artery bursts. The high-pressure arterial blood hydraulically strips the dura off the bone.
And on a CT scan, this has a classic shape. It looks like a lens.
A biconvex or lens-shaped hematoma. Because the dura is tacked down very tightly at the suture lines of the skull, the blood can't spread out. It's contained, so it pushes inward, compressing the brain. This is the classic talk and die syndrome. The patient has a lucid interval and then crashes as the pressure builds.
Okay. Next space. The subdural space. Between the dura and the arachnoid.
This story involves veins. The bridging veins travel from the surface of the brain, cross the space, and drain into the dural sinuses. Veins are low pressure. If they tear, and this often happens in the elderly or in alcoholics from even a minor fall, the blood oozes out slowly. It doesn't have the force to strip the dura, it just spreads out along the surface of the brain.
So on the scan, it looks like a crescent.
A crescent moon shape that follows the curve of the hemisphere. It's much slower. It can present days or even weeks after the initial injury. Very different picture.
And finally, subarachnoid hemorrhage.
This is bleeding into the real fluid space, the CSF space. The cerebrospinal fluid literally turns to blood. This is usually from a ruptured berry aneurysm in the circle of Willis. It's explosive. The patient describes the worst headache of their life, the thunderclap headache.
Because the blood is in the fluid.
Goes everywhere the fluid goes. On a CT scan, you see this white, high-density blood tracing its way into all the sulci and cisterns. It outlines the brain like the branches of a tree.
So lens equals epidural, crescent equals subdural, and tree or diffuse equals subarachnoid.
That is the radiologist's mantra for head trauma.
Almost there. Slide 14. Dural reflections and sinuses. The dura isn't just a simple bag. It has its own internal architecture.
That's right. The inner layer of the dura folds in on itself to create these rigid partitions inside the cranial cavity. It helps to stabilize the brain so it doesn't slosh around too much when you turn your head.
The falx cerebri?
That's the big vertical sheet, like a sickle, that runs right down the midline and separates the left and right cerebral hemispheres.
And the tentorium cerebelli.
That's the big horizontal sheet. It forms a tent over the cerebellum, separating it from the occipital and temporal lobes, which sit above it.
This is why we talk about lesions being supratentorial or infratentorial, above or below the tent.
Exactly. But these rigid sheets are double-edged swords. They provide support. But if the brain swells, it has nowhere to go. It gets pushed up against these sharp, unyielding dural edges.
And that's herniation.
Yes. Uncal herniation is when the uncus of the temporal lobe gets pushed down under the edge of the tentorium. It crushes the midbrain. It is rapidly fatal. The dura provides support, but in the context of pathology, it becomes a trap.
And the sinuses.
The edges of these dural folds, where the two layers split, form these large tubes, the dural venous sinuses. This is the main drainage system for the brain. All the venous blood and all the used CSF drain into these sinuses to get back to the jugular veins and then to the heart.
We made it. Slide 15, summary and integration.
We have painted the rough sketch of the mural.
Let's just recap the 4 corners of this mural we've painted. 1. Structure reflects history.
Z-shape. The C-shape of the ventricles, the caudate nucleus, and the fornix is a direct physical memory of the fetal rotation of the telencephalon.
2. Orientation matters.
You have to respect the cephalic flexure. The coordinates change at the midbrain. Dorsal means back in the spine, but top in the brain.
3. Organization.
Gray matter processes. White matter transmits. And remember that inside-out flipped arrangement between the brain and the spinal cord.
And 4. Protection.
The PAD layers. The pia, arachnoid, and dura. Their anatomy directly determines the mechanics and appearance of hemorrhage and herniation. And this rough sketch is the map we're going to use in the very next lecture. Lecture 5 is the neurologic examination. We're going to take this map and use it to diagnose patients. We call it localizing the lesion.
You can't fix the wiring if you don't know where the wires go.
You can't. And you can't read the map if you don't know how it was drawn, which is what we did today.
So for everyone listening, your homework. Close your eyes and visualize that C-shaped rotation. Trace the path of that CSF swimmer from the lateral ventricle all the way out into the subarachnoid space. And please, look at the images in Haynes Chapter 4. You need to see these colors and shapes for yourself.
As Blumenfeld says, the nervous system is the most beautiful, elegant, and complex system in the body. Today, we built the frame. Next time, we start turning on the power and testing the circuits.
Localization, localization, localization. That is the mantra. Thank you for diving deep with us. We will see you for the neurologic exam.
Until then, stay curious.